Yeah, I think we are
This
live.
video stuck. I said,
No, it's not happened yet.
No, I can see live on YouTube.
Yeah, but give me 1 minute. Yeah, it's live now. You can go ahead.
Okay, Dhiren bhai.
Yes, welcome Dr. Reinald Brunner to POSI webinar. You are coming to this webinar for the second time, and you are a good friend of POSI, and you are been at our POSICon very frequently. So, like, I don't think that our audience needs introduction, but still I will request Dr. Matthew to introduce you formally. Over to you, Dr. Matthew.
Thank you, Dhiren bhai. Good evening, everyone. It's a pleasure and honor to have Dr. Reinald Brunner with us. And as Dhiren bhai said, he needs no introduction with the orthopedic surgeons in India because he's a great friend of India. That's the first important thing. But I have the honor and duty of introducing him. He is a pediatric orthopedic surgeon, neuro-orthopedic physician at the University Hospital in Basel, Children's University Hospital in Basel. There are several achievements that he has, but the most important, I would say, he's on the editorial board of Journal of Pediatric Orthopedics. He's an associate editor of Gait and Posture Journal. He's on the editorial board of Orthotics and Prosthetics International. So he is an academic orthopedic surgeon. He's a great friend. He's a wonderful host. I've had the privilege of spending time with him and watching him running from his clinic to his wards to his theater. And I kept following him. And my word, what a mannerism with his patients, impeccable bedside manners. And the most important thing, I was going to say that earlier, but the most important thing I've seen about him is he's a thinking orthopedic surgeon. One of the most cerebral orthopedic surgeons who comes with lateral thinking and something that others not thought of. And that's a mark of genius, that you need to be thinking beyond the ordinary. So it's indeed a pleasure to have you, Reinald. Thank you so much for joining us here. And he's going to start off the session on management of foot problems in ambulatory children with cerebral palsy. So over to you, Reinald. We will listen to you, and we will have question and answer sessions, and we have Swapnil and others adding on, and Gopa adding on questions from the faculty and adding on questions from all the audience that is there. Over to you, Reinald.
Thank you, Matthew, very much for these very kind words. Actually, too much flowers, I think. I don't really, it's too much of an honor for me, especially by you, because I know that you're a very hard worker and as well a very good thinker. Thanks very much, Matthew. I really appreciate this.
Thank you.
It's my pleasure, and I thank you very much that I can give another webinar, and I will talk about the ankle problems. Now, okay. We have a great variety of foot deformities in our CP patients, in our ambulatory CP patients as well. And what I try to do in the next minutes is to put in some order to talk about the causes. Why have patients these deformities, especially the ambulatory patients? What are the consequences for the feet, for the patient, for the function, and what is a possible treatment? The aim of treatment in these patients is to restore the foot function. This is the first and most important goal. And the second aim is that we should prevent secondary functional disorders, which are caused by the evolving foot deformities. So the content of my webinar will be, I will talk about the functions of the foot and causes of foot deformities, causes of equinus, the development of these foot deformities, and again, the consequences that these new deformities have for gait, the plantar valgus and the cavavaris foot, and the possible treatment, conservative and surgical. Now, the most important function of the foot is what we call the plantar flexor knee extension couple. I call it plantar flexor knee extension couple. I don't know how it runs. The plantar flexor knee extension couple because it's the plantar flexors and not the plantar flexion, which is the acting item. It's the plantar flexors which pull the tibia backwards and by this fact extend the knee, especially if we walk and the center of mass moves forward. And this mechanism is actually extending our knees. That has been published 2004 in Nature. And to be efficient in this in this plantar flexing mechanism, we need to have preconditions in the other joints, which means full hip extension, full knee extension, and a plantigrade foot. But I really would concentrate on this. It's actually a rectangle between the sole of the shoe and the tibia, not the foot necessarily. And if you lose your plantar flexor knee extension couple, that's what you see in this little video, then you will increasingly flex your knees during gait until you have a severe crouch gait. The next important task of the foot is to produce dynamic stability. And for that reason, we need the foot having in the direction of your leg, in the direction of gait. What you see here is in this video that if you have a malrotated foot, you get twisting forces which produce an external or internal rotation. And while you're rocking on the foot, you actually increase these torsional forces and your leg is actually getting out of the direction and your foot as well. And that can actually go as far as in this patient where the foot at push-off points backwards. I couldn't do a gait analysis because the foot rotation was 100 degrees. This is really a lot. And what you then have is with every step, you twist your leg. And by twisting your leg, twisting your foot, you act on your growth plate. And what I've seen is that patients where the feet are out of plane, out of the direction of direction of gait, then you have an increase of tibial torsions in either way. And in my patient cohort, I have foot deformities which produce malrotations, but I hardly ever have tibial rotational deformities because I always keep the feet aligned in the direction of gait. This is not the case in other countries, and they have far more rotational deformities on the tibia level. The next task is the area of support. We normally stand on the complete foot, so toes almost and the heel are loaded. This is a large area. If I'm moving on my toes only, the area of support gets very small and I'm feeling unstable. I have an unstable posture when I have such a little supporting area. And the easiest thing is to add on a heel, as here, or as this lady shows. She has a very relaxed position because she feels at ease. Her support area is large enough. And we can do the same thing in patients where the equinus, for whatever reason, cannot be operated on, or the operation has to be postponed. Then you can actually add on a heel and the patient can stand in the similar relaxed position like this lady. So you actually have to compensate the equinus, the true equinus, by a heel. Now you have to distinguish between two different deformities, the true equinus, which is an overactive plantar flexor muscle, and the apparent equinus, where the problem is actually not in the foot level, but at the knee or even hip level. If you deal well with your foot deformity, in the case where the foot is the main problem for the gait problem, then you can solve your gait problem with this treatment. Whereas if you have knee problem, you still load your toes, you get similar problems like secondary deformities and everything, but even if you solve your foot problem, you will not solve your gait pattern problem. So this is a major difference that you have to be aware, that you have to distinguish between a foot and a knee or hip problem. Now, why does an equinus occur? We know that these patients all have spasticity, and spasticity is always accused to produce these hyperreflexic, hyperactive plantar flexors. And this hyperreflexia could be one part of spasticity, or what is here, or you can actually have stiffness, as you see here. Both types of spasticity may produce plantar flexor overactivity. But we know that spasticity is not a problem which is remaining over time. So the importance of spasticity changes with aging, and actually there is a maximum in age 4-5, and then it comes down. That's what Gunnar Hagland has shown in a study 2008, and we should not forget about this. We studied another cause for equinus positions or plantar flexor overactivity, and that is muscle strength. There are different groups of patients which we had in our gait lab. There are orthopedic patients, uni or bilateral ones, neurological patients with flaccid paralysis like unilateral or bilateral ones, and spastic patients. And we grouped them in patients who had a normal strength and patients who had a reduced strength. Normal strength in blue, reduced strength in orange. And what you see is whenever you have a reduced strength, you have a higher rate of patients who have a plantar flexor overactivity. So just weakness can be a cause for plantar flexor overactivity. I know that psychology is something which is very far away from orthopedics, but we still have to include it if we talk about equinus. If you feel insecure, you will also go and use your very ancient method to stabilize your leg, that is plantar flexor overactivity and keeping the knee in extension. This man here, I downloaded it from the internet, is crossing the Grand Canyon in the United States. So I wouldn't feel at ease, I actually wouldn't do it. And he does, but he walks like a spastic patient. This is obvious because he has a fear of falling down thousands of meters. But our patients do the same thing, and the walking pattern has similarities. This patient feels not at ease because he has fear to fall down, and these patients they don't feel properly their legs. We know that all spastic patients have sensory affections as well. And although they walk on even grounds, they have a similar fear to fall. And for that reason, stiffen up, overactivate their plantar flexors. And this man uses a bar, these patients uses the arms, but for the same reason, is to keep balance. And the next factor is another psychological factor. It is learning patients. Now I have, yeah, okay. If you have the first steps, and this is first steps of one of my grandchildren, what he shows is plantar flexors and hyperextension of the knee. So he stabilizes his leg, makes a column out of his legs with segments by plantar flexion and keeping the knee in extension. And this strategy actually is learned by patients as well. And they use a similar strategy here. You see how he extends the knee by his plantar flexors when he is walking. So this is another part which we should not forget. If patients learn that this strategy works, they are in no need to change this strategy. And finally, we should talk about retardation, which is another factor why they keep this early on learned strategy. So let's go to this patient who has a hemiplegia, and we think it's very easy. He has a spastic hemiplegia, so spasticity is a problem. But if we look at all possible, at least the possibilities that came in my mind, for plantar flexor overactivity, we have, yes, spasticity, but it's a very mild spasticity in this patient, but that could be a possibility. Then the hemiplegic side is short by 2.5 centimeters. Now, usually short leg would be compensated first by shorter steps, but that is not the case if the leg length discrepancy is large. And these 2.5 centimeters occur very early in hemiplegic patients, and then they just keep this difference over time. So initially, when the patient was small, he relatively had a much higher leg length discrepancy, and for that reason, yes, it could be one other cause. Then he has a structural equinus, which is certainly a cause, so this is clear. He has sensory deficiencies if he feels insecure, so another reason. He has a developmental retardation, at least on this side. This is again a reason. He has muscle weakness, and again, for this muscle weakness, he feels unsafe in this leg. Again, a reason for plantar flexor overactivity. And then we have gait velocity, which does not really show to be a possible cause. So we have several causes which have very different origin, and only few really would be helped by treating overactivity. The others actually use overactivity as a compensation. And we think we need to be aware that all this may happen and that we have no clear tool to distinguish between these possible options. Especially gait analysis does not show the cause. It just shows the hyperactivity. But the cause, finally, is relevant for our clinical treatment plan. Now, what happens for the patient? If the patient is walking on the toes, I showed that already, he gets problems with equilibrium and body control because of the small support area. And the leg and the whole position is functionally unstable. But this insecurity has further consequences. The insecurity in function reduces the level of activity of the patient. He does less because he is afraid of doing things where he could be injured. So he does less things, has less inputs, and for that reason, he learns less and ends up in a developmental retardation. And the second problem is the danger of foot deformation. If a foot is loaded this way, it is not sure that the foot will not be deformed because of this overload. What is the consequence of equinus for gait? Plantar flexor overactivity, or actually toe walking just by itself, even if it's caused by the knee, produces an flexion, adduction, and internal rotation at the hip joint. This is forward modeling. This is not an animation, and it shows soleus overactivity under load. And I think this is very important that we understand that hip internal rotation in a patient who is walking on the toes is much less caused by anteversion. It's far more caused by the plantar flexion. And you see here, this patient, it's just by chance that I did not do any femoral correction. She was walking very much internally rotated on the right hip, less on the left. We mainly did an Achilles tendon lengthening. We did some hamstring and adductor lengthening as well, but we never corrected femoral anteversion, and you see the result 1 year later. And actually, she stayed that way. So if you correct the plantar flexor overactivity, you have a chance that the rotation gets settled. For the foot, there are other consequences. If you overload your foot by loading only the toes, could be by plantar flexor overactivity or by knee flexion, doesn't matter, then your foot is in danger. And for ballet dancers, at least in our country, a foot deformity is accepted as a professional disease. And they are obliged to protect their feet, and they are much less on the toes than our patients walking on the toes. And if they remain unprotected, and that's what is commonly the case, then the foot gets deformed in either way. Could be in varus abduction, a varus cava varus, or valgus abduction deformity. How can you prevent this? You can actually correct your distance between the heel and the floor by adding on a heel. This patient with diplegia walked on the toes, and when I give her high heels, what she's walking in a heel-toe gait, and she has no internal rotation anymore. And I need to protect the foot by some kind of orthosis which keep the foot aligned. This could be a short orthosis or a high orthosis. And if I want to provide stability for walking as well, then I need to get up to the, below the knee, and then the patient feels more stable. As I said, you can either go in the direction of plantar valgus or of cava varus feet. And if you have a plantar flexor overactivity, the most common cause is just load in walkers. There is muscle pull and weakness of the counteracting muscles. In other patients, which are only standing especially, or even in GMFCS5 patients, they produce these deformities. But in walkers, it's mainly load by itself. And these deformities are usually progressive, and the more these deformities progress, the more walking is impeded. And together with the deformity in either plantar valgus or cava varus direction, the foot produces a supination deformity, and the triceps become short, and I show you that here. And all these components need to be checked before you plan your treatment. So if I have a plantar valgus foot and I correct the heel, put the heel in the correct position, you see that the foot goes in supination. And this supination can either be rigid or supple. If it's rigid, you need to correct this deformity as well, because it's a structural deformity. This wooden trap here shows the distance between the insertion, the origin of the soleus and the insertion of the soleus. And if I put the foot in a plantar valgus deformity position, you see that this suture here becomes supple. It is not under tension anymore. That means that the distance in the foot deformity between origin and insertion for the triceps surae is less. And that means that the muscle can become short without we realize it. And that is what is then found if I put the foot in a correct position and the foot does not get any more to 90 degrees. If I splint the foot in this position, I have no influence on the stretch of the triceps surae muscle. So that's one reason why I always put the foot in the correct position, and then I get some kind of stretch when the patient is walking. But I have then to accept the deformity of equinus. You see it here as well. You have a foot which is mobile. There is an instability more in the shop bar joint. This is the midfoot joint, and less in the subtalar joint. And you see that when I dorsiflex the foot goes into abduction and external rotation as well. So the plantar flexors impede some movement in the ankle joint, which goes further than a certain degree, and then the remaining dorsiflexion occurs in the hind and especially in the midfoot, and the equinus is masked. I have to consider this when I treat these patients. Now, the problem is that has some effects on the leg and on walking as well. So if I hold the leg stable, that's what I usually do when I examine the patient, then the foot moves. So you see here this outward rotation and abduction. But if I keep the foot aligned and let the foot go to midfoot break, you see that then the leg internally rotates. So the same mechanism actually produces an internal rotation and a misalignment. And this misalignment can be so severe that the patient loses control on the leg. That is what this patient shows. You see this internal rotation when this patient is rocking on this foot. So the more he's the more she's getting into mid-foot break, the more her knee is going to flexion and internal rotation. And the plantar flexor knee extension couple does not work anymore. And we published this actually. There's a correlation between this foot deformity and the knee rotate and the hip rotation. In very severe cases, then it ends up in a severe crouch gait because there is no working plantar flexor knee extension couple, and the problem is that the foot gets even more deformed, the leg and the foot are unstable, and the lever arm is very short for the plantar flexors. The cavovarus foot actually is, in my opinion, in my hands, much less a problem. Yes, the patients are unstable. The patients have a smaller loading area, and they sometimes have severe deformities, but usually the knees still are extendable and are extended. I've never seen a patient with a cavovarus foot who produced a crouch gait deformity. So this is more dealing with a foot problem, whereas the other deformity is more severe. The consequences are of these foot deformities are you have an equinus that can be, or toe walking actually, which produces a hip internal rotation. And maybe this is not proven, but there are indications that you have an increase of anteversion secondary. The equinus can produce a knee hyperextension. We always treat it, but sincerely, I have hardly seen patients with cerebral palsy who had problems with this knee hyperextension as a child. It can go to cavovarus or to planovalgus foot. Whatever happens, these foot deformities produce a dynamic instability, and we should always consider this dynamic instability reduces the activity and has an effect on the whole performance of the patient, like motor retardation and a lack of neuromuscular control. So this is not just a foot deformity. It's not just a gait disorder. It is really a problem which affects the whole patient. As I said, there are also, at least in my patient cohort, there are indications that if you do not correct this malalignment of these feet, this external or internal rotation, you may actually produce a pathological tibial torsion. So what are the aims of treatment? We need to reconstruct the lever arm as in the first place. We should get the foot aligned, and we should recover the support area. And our treatment should incorporate the structural deformity, functional deformity, and the rotational deformity. And we have conservative and surgical tools. What I'm always a bit cautious is with doing surgery just to fit orthotics. I think that is something which in the modern techniques of orthotics should not be necessary anymore. That was the case when orthotics were made from aluminium or steel, and you have to adapt them to the foot. That was very difficult if the foot was deformed. But nowadays, where you can actually produce prosthetics in very deformed limb deformities, you should actually be able to incorporate any deformed foot as well. So let's talk about conservative treatment. The functional deformity is obvious, and I can actually correct this functional foot deformity because it's subtle. But what I do is I push underneath the heel, what you see now, and when I push here, you see that the foot actually corrects. So this abduction planovalgus foot deformity is just corrected by pressing underneath the heel, nothing else. And if I press here and a little bit in the midfoot area, then I actually correct this deformity. If I press only in the midfoot part, I actually produce even more abduction deformity. So you really need to incorporate the whole foot in your conservative tool to get a good control. And this is especially more important because if you walk, you have first only load on your heel, then load on your midfoot, and then load on your toes. And to keep the foot aligned, you actually need to cover all these various support areas to get the foot, to keep the foot aligned. So initially, it is the correction of the heel in a varus pad or varizating, a pad which produces varus of the heel. Then a pad in the midfoot for the mid stance time where the midfoot is supported, and toe off needs to be covered as well, especially if you have a rigid supination deformity, and the foot would actually go into abduction as well with overpressure in the midfoot area if there was no pad to compensate for this supination deformity. This can be for the cavovarus deformity, you just have to be respective pads. So if you have a rigid supination deformity, you have to accept it. You cannot correct with functional orthosis structural deformities. This is not possible. So you have to accommodate the deformity, and your orthosis looks like this. Even more like this. And you get a platform which produces a functional foot. Now, if you cannot accept this deformity, you need a surgical correction. But this is something that needs to be discussed in the individual case. I'm aware that it is sometimes difficult to accept such a problem, but in some patients who have severe other diseases and may not be fit for surgery, this can be the only option, and you should be aware that it is possible with today's orthotechnical tools. I do not look at anything else to see whether the foot is well corrected than foot rotation when the patient loads the foot. So this is the same patient. He has a flat abduction foot deformity here. And when I correct this foot, the foot gets aligned. So if my orthosis, and this is a foot orthosis only, corrects the foot deformity, the foot gets aligned. And that is what I look at. And that is working in this case without any other liver arm. Sorry. We want to restore the plantar flexion knee extension couple. It was destroyed in this patient. And if I add on a liver arm together with stabilizing the foot and keeping the foot in the direction of gait, that what we tested with this cast, you see that she's capable to walk with extended knees. It doesn't matter for these orthoses whether you push from front or you pull from the front, or you pull from the front. It's like a locomotive which pulls or pushes the train. Physically, it's the same thing, although they have different names, but they are equal considering the efficacy for this restoration of the plantar flexor problems. The important thing is that your shank axis, which is the anterior board of the tibia, is perpendicular to the sole of the shoe, not to the foot. And if that is the case, like here, you can have a well-aligned foot, a foot which is in a normal anatomic position considering the bones, but has an equinus problem. And if you can either compensate for the equinus or correct the equinus. And this is one of the extreme patients. He had a midfoot break with complete dislocation in the midfoot joint, and has a plantigrade, almost plantigrade foot with this dislocated position, and that is his maximal dorsiflexion when the foot was reduced. He actually played with his foot and produced both deformities. That's why he remained so supple. He would need such a high heel to compensate for his plantar flexor shortness. AFOs, or all orthoses, actually have a biomechanical effect, not only the effect that we want, that means to replace the big plantar flexors, but also they may produce deformities if they have biomechanical errors. And one of the biomechanical errors, for example, is rotation of the foot part against the shank part. This orthosis is made in internal rotation. You see the condyle plane here, and you see the foot, and that should be actually in the direction of the leg, meaning perpendicular to this plane, intercondylar plane of the tibial condyles. Similar here, you have a foot which is aligned in a spontaneous position, but when I put on the orthosis, the foot is out of axis, and that should not be the case. And you have the next problem, that is varus. Varus can be in the proximal part, can be in the distal part, but it's even more important that it is not occurring in the proximal part, because what happens is that in the unloaded position, that means swing phase, the foot is displaced medially in respect of the axis of the leg, is loaded on the lateral border, and then, as I showed in the initial video, the foot starts to rotate while the leg is loaded. In this case, it would rotate internally, and the leg gets out of order and becomes unstable. So we have to be aware that we have to look at these things when we check our orthotics, and that can be important. This is a patient, she has a congenital paraplegia. That doesn't matter very much what she has, because biomechanics have the same principles. She's walking much better with the orthosis here, but you see that especially on her left, she still falls into too much into knee flexion. She's coming again. And what you see is that this orthosis on the left side shows mild varus and internal rotation. And we only corrected this orthosis, so it's not a new orthosis. And that's how she's walking afterwards. And now she's actually more stable in her leg. So this is important. And I think if we do conservative treatment, we should be aware that we can do good things, but we can even do bad things. Now we have other options like botulinum toxin for functionally short muscles, which in my hands has lost importance because it's only transient considering the efficiency. It weakens an already weak system. It is only helpful in the case of spasticity, and I'm not sure whether all of my patients really have spasticity as a main problem. And there is a danger that if I take off spasticity in patients who walk with this spasticity, that they actually can deteriorate. And the other possibility is casting. Casting has been very much done in the last two decades ago, in the 90s. And we had good results. You see that here, that's a difference of 2 weeks. But again, it's only transient. Usually it works over atrophy, and when the muscle strength recovers, you actually have the same problem as before. And again, it weakens a weak system. So in my hands, these things are all of little help. The other options is surgical. And if I talk about surgeries, I now tell you principles again, not techniques. So we can, if we have muscle pull, and that can be any muscle which pulls, we can either release or lengthen the muscle. We have an equinus, so then we need to lengthen the triceps super muscle tendon complex. I come to that again. If we have a cavavarus foot, we could do a tibialis anterior split or complete transfer, tibialis posterior split, and sometimes even a plantar fascia release can help to reduce this cavavarus deformity. In the plantar valgus foot, we can have short peroneal muscles and we can lengthen them as well. And in a drop foot, we have a tibialis anterior tendon, which we can shorten, as I've shown in some papers. We talk about that later on, or we can transfer toe extensors or even toe flexors to overcome this drop foot deformity. In all my experience, whatever you do in this direction is only partially efficient. And important to say that it doesn't work anymore if you have bony deformities. Now, what is the principle of muscle lengthening? You have three major options. One option is just to cut the tendon. You get a huge gain of tendon length. You do not touch the muscle belly. The next thing is you have a well-defined lengthening by Z technique or the hook technique, which is a bit less controlled, and you gain a defined length. You again do not touch the muscle belly. And then you can touch the aponeurosis, which is called intramuscular lengthening. And today there's an increasing importance because we call it fasciomyotomy or ulcibat or these techniques. And this is all the same in principle. I show here the principle of the biomechanical effect of these techniques. What we know is that if you have the normal active muscle force curve here in red, and this muscle force curve actually is located within the range of movement of the joint in a way that it controls this joint best. And you know that you have an optimal force at a maximal force at an optimal length. If I do an intramuscular lengthening, I gain little length and I do not actually weaken the system. If I do a Z lengthening, especially if I do a bit too much, I shift this curve out of the range of motion. The muscle, because it is not active anymore the same way as before, we go to atrophy and seems to recover because it is more, it's producing a relatively more force then in the shorter position, because it gets shorter when it goes to atrophy, but it is only a pseudo correction because the maximum force will always be reduced. And this is even more the case if you do a tendon release and the muscle will not recover at all. And this principle actually we should keep that in mind, because the length gained in this technique is only gained by stretch. So if I cannot do stretching for a patient, this technique will not work. These techniques will produce length, whatever the patient does and however cooperative the patient will be. For the triceps surae, this is a bit more complex because the triceps surae has an insertion of the soleus which goes further down, and the gastrocs are inserting a bit on a higher level. So that means we can either do a Z lengthening or a tenotomy, and we lengthen all components by tendon lengthening. Tenotomy the same, but it's uncontrolled. The percutaneous technique again lengthens all components. The control is less. That is this hook technique. And the strier actually only proximalizes the insertion of the gastrocs and does not touch the soleus, but it's functionally it's a tendinous lengthening of the gastrocs. If I do intramuscular lengthenings, I can either do it in the dorsal fascia of the gastrocs only, then I have only the gastrocs lengthened. The Baumann allows to do it in the ventral fascia of the gastrocs and the dorsal fascia of the soleus at the same time, and then I lengthen both or three parts by an aponeurotic lengthening. The vulpus is an aponeurotic lengthening of the soleus done distally of the insertion of the gastrocs, and this way you lengthen the soleus in an aponeurotic way or intramuscular way, but the gastrocs in a tendinous way. And the percutaneous fasciomyotomy does the same thing like Baumann or the vulpus wherever you do it. So this is a mixture and it is a bit less well described. The problem is that if you do Z lengthenings or tendon lengthenings, there is big gain of length, but a danger of overcorrection. In the other intramuscular parts of types of lengthening, you gain much less length, and weakening is much less a danger, but you only get length by pulling, by stretching, and there's a higher incidence of recurrences. Now, what about early correction of equinus? And I really want to warn about that. And I now have several patients who have the same outcome like this patient. I was always asked to operate on this patient for his poor gait condition. I always said it's not an orthopedic problem. And you see, without touching this patient, he never had Botox, he never had surgery. He only had physiotherapy and an AFO. He actually developed this gait pattern. And this is actually due to a feeling of security. He feels better, he feels safer in his legs, and for that reason, he walks better. If I do surgery at that time, in a diplegic patient especially, I have that danger. So a late crouch, because even this patient will have less pull on the plantar flexors and then will actually overload the knee extensors, and she will have a bad outcome at the long run. Although first, initially, she had a good outcome. So yes, they improve for for 2 or 3 years, but then there's a great danger that they are deteriorating a lot and they are difficult to treat. Now, what about bony surgery? You have patients from GMFCS1 to GMFCS4 who are on the feet. They are more mobile, they require more stability, they have more flexible deformities, they have more rigid deformities. They should be reconstructed with less fusion and they with more fusion. They profit from more mobility, they profit from more stability. The options are in the hindfoot, the subtalar fusion, or the calcaneus shift or wedge osteotomy. You can have in the midfoot the calcaneal lengthening, which is not producing any stability of the midfoot, or the calcaneocuboidal lengthening fusion. You see here the bone block, which is inserted, the tenonavicular fusion on the other side, or a Chopin fusion if you want to correct rotation as well. And that is done here. You can have, if you have a supination deformity, you can either correct the first ray here or further in front, or you can do a Chopin fusion or fusion here, or you can do a midfoot osteotomy and twist the foot. And if you do a Chopin fusion together with a subtalar fusion, you get a combined called triple fusion, which is shown here. And yes, I think you have to decide where the major instability is located. If it's more the subtalar joint, it's more the hindfoot which should be corrected. If it's more the midfoot, which is commonly the case, especially in these midfoot break patients, then you should go more to the midfoot. A few words to the calcaneal lengthening. It actually does not work at the long term if the patient is not developing a heel-toe gait.
Reinald, sorry to interrupt you. Your slides are not moving. It's only at the lengthening slide.
Sorry?
We
are here.
No, they are not moving.
I can see them moving.
I can also see them, sir. Yeah.
Okay.
I think it's your connectivity, sir.
Okay, sir. Okay.
Okay, good. So if you do not have a heel-toe gait, the patient will touch with the toes first. We all circumduct. And for that reason, these patients, if they still have first initial contact with the toes, have a high recurrency rate. And in this case, this is a good indication for a calcaneocuboidal lengthening fusion instead of the calcaneal lengthening alone. So in a GMFCS1 who has a heel-toe gait, yes, that's the indication for calcaneal lengthening, but not in the other patients. Now, the problems of surgery is tendon releases and lengthenings have a recurrency rate. They are not efficient if there's a bony deformity, and for that reason, you need to do it early. But there's a recurrency rate because of growth as well. Tendon transfers are similar. If you do a tendon Achilles lengthening, you have the danger that this the neck of the talus here actually may be filled up as you see it here. And then if the patient dorsiflexes, there is impingement. So you should do this surgery not too late. And if there is this impingement, you need to correct with arthroscopic shaving or with open resection of this bony part to overcome this impingement problem. Joint fusions should be done rather late because you lose the growth cartilage as well. And if you do it very early, you actually risk a short liver arm at the long run and a secondary bony deformity due to asymmetric growth. And the other problem that has been obvious in my hands is that even if you put everything in a very nice position, but the bone is very osteoporotic, there is a problem that there's a tendency of recurrence already in the cast. And for that reason, you should consider tendon releases in these bony corrections in osteoporotic patients. So coming to the conclusion, the functions of the foot, liver arm, support area, alignment need to be maintained and restored. Equinus can have multiple causes, from knee problems to diverse reactions which produce plantar flexor overactivity, but it is often the initial deformity, and in combination with load and poor muscular control produces additional foot deformities, which produce additional gait problems. The functional treatment can be done either conservative, then you need to correct the functional deformities, but you should accept all structural deformities because you can't correct them, and just adapt the orthotics respectively. And if you do surgical corrections, then you correct both functional and structural deformities, but be careful with early TA lengthenings. And be aware that soft tissue corrections are poorly efficient if there are already bony deformities. So lastly, the same aims are need to be fulfilled. Whatever you do, conservative or surgical treatment included, the first is restore the liver arm foot in whatever position the foot is. Second, correct rotation. No alignment, because alignment produces instability and crouch gait. Stability is the third. So try to put on enough heel if there is an equinus which you can't correct, to enlarge the support area or correct the plantar flexor length. And lastly, we should go for a first rocker, because then you have enough surface of support and you overcome the internal rotation problem secondary to the gait on the toes. And you need to correct the dog foot deformity, but there is a problem, because if your brain has learned a strategy with a drop foot, then it is difficult to get rid of it. Now, what I did is I only presented you principles of treatment, because I think that there are various techniques and they really depend from the local and individual situation, and how you fix things, that's up to you. But the principles, I think, remain the same. And what you should always be aware is you only solve the gait problem by correcting the foot if the foot is the only problem for the gait problem. Okay? Thank you very much for your attention. I hope I was clear.
Thank you.
Yeah,
Thank you.
thank you, right. Yes, Matthew, can you start with your questions?
Yeah, thank you so much, Reinald, for a fascinating session, highlighting the importance of true equinus versus apparent equinus, highlighting the importance of the plantar flexion knee extension couple, and a fascinating use of orthosis, which I had noticed when I was visiting your clinic, because a lot of times the kind of deformities that come, your orthotist was there, hands-on, trying to mold the foot to get the foot on the ground, to get the alignment between the tibia and the ground right angle. And that was a brilliant exposition of that. And amazingly, reducing the usage of Botox. That's an important message that I see here. And also highlighting the dangers of early surgery, which leads on to late reversal or problems of crouch that are there. And thank you for highlighting the principles. To start off with the questions, I'll start with the orthotic part. Many of the orthotics that are there, these are customized and made to perfection on the foot deformities that you have coming to your clinic. Do you have any tricks to ensure that it is exactly as per your needs and what you have planned? You have an orthotist coming. Many of the orthopedic surgeons may not have such a skilled orthopedic surgeon. So what do they do in such a situation?
I usually try to show the ortho technician where I put my pressure on the foot. And I try to show them that I only need pressure from underneath, and in a cavavarus foot sometimes on the whole length of the fibula. So I really try to get the hands of the ortho technician on the foot with my hands on top, that they can feel how they should correct the foot from underneath. And I think if they realize that once, then they will realize that it works in their patients.
Yeah. The reason I asked you this question was because in several of your slides, you can see the foot is molded within a special orthosis where the ground tibia angle is perfectly aligned. And that is an important message that I see here. Instead of running in for surgery, many of these patients can be managed with that kind of an approach. I think Gopal wants to ask some questions. I leave the floor to others to ask questions and chip in whenever I think there is a need.
I want to ask regarding the foot in crouch gait. Are you audible, sir? Am I audible?
Yeah, I'm here. I'm listening. I'm not asleep, not at all.
By definition, it is the dorsiflexion is increased, isn't it, in crouch gait?
Yeah. But what is dorsiflexion?
Dorsiflexion is increased. Yeah. But when we do a calcaneal lengthening, the equinus that is obscured will become overt. Many of these cases will have plantar flexion. Yeah. But still we call it as crouch, isn't it? So by definition,
we actually do not call it crouch anymore if you walk on a foot which is in an equinus position or normal position. We only call it crouch if the foot is dorsiflexed. But we should be aware that dorsiflexion can arise from the ankle joint, the subtalar joint, or the midfoot joint. And that's the problem. We just call it dorsiflexion. If you have dorsiflexion arising from the ankle joint, then your tendon Achilles or your triceps is overly long. In all the other cases, actually, this muscle is usually short, and it's the hypermobility of the joint which actually produces this dorsiflexion. So this is a completely different situation. And if you then produce a stable liver arm, then you actually have a short triceps because you demask your shortness.
Okay.
And then you should lengthen your triceps if that is a need. So then I do both. Then I should actually, if I have a severe midfoot break patient and I reduce the foot into a neutral position and I get the bones aligned and then the triceps is overly short, I accept 5 degrees of plantar flexion deformity. But if I have 15 or 20 degrees, then I do some kind of triceps lengthening as well at the same time to really adjust the foot to adequate position.
Yes, now we have audience questions. So Swapnil, can you ask those questions to Reinhard?
Right. So the first question coming in is that cerebral palsy is as much a science as it is a philosophy, which tends to differ as much a science as it is a philosophy of treatment. So what is your protocol when you see a patient, right from the time the patient comes to you till the time you decide to either do a surgery or give an orthosis, or what are the steps of management?
Depends on the age. In a young patient, in a young child, I do I always do a thorough clinical exam. I examine the range of motion, the muscle length is. I always look at hypereflexia. I always look at spasticity, and then I see how he or she is walking and see how that coincides. As soon as the patient is capable to go to a gait lab, that is age 7, some 6, 7, 8, depends a little bit on cooperation, I actually take the patient to the gait lab, because then I want to know what the cause is. And then we have new techniques in our gait lab, which helped me going through all these thoughts about causes of equinus. What we do actually is we have a model where we can mimic a simple model where we can mimic spasticity, short muscles, long muscles, weak muscles, and we can see which type of walking of this model comes closest to the patient's walking pattern. This is something which is still in progress, but it gives me an indication whether it is probable that it is spasticity or another thing. And very often, actually, I find that the model would detect other causes, not spasticity, in a spastic patient. And for that reason, I then check what the causes are. And then the next step is when I define the causes, I still have the problem of walking on the toes. But I would, in a very small child where spasticity could be a problem, I first try an orthosis. But if there is a severe problem with orthosis and with everything, I may consider botulinum toxin in the very young patient, not later on anymore. And in the patients older, I first go to orthotics, see whether it works. And if it doesn't work, I go to surgical possibilities. I discuss it with the patient. I then use botulinum toxin or conservative tools. There are different possibilities and options to test my biomechanical hypothesis best possible to show whether my planned surgery would actually have a high probability to reach the aim that we have. I think we can test these things. So I do not indicate surgery from the clinical assessment simply. I go and see whether I have some tools where I can test my hypothesis first. Is that answering the question, I hope?
Yes, yes, that is what they wanted, the flow of your treatment. The second question coming in is, what in your practice is the indication for a tendo-Achilles tenotomy in cerebral palsy today? What is the indication? Is there an indication? Is there a role?
It may be considered in adult GMFCS5 patients who doesn't do anything, doesn't use his feet. But if you do a tenotomy, you actually risk the opposite deformity. So be careful. I remember a patient who had similar things done to the knee. He first had a cut of the hamstrings, then he had a knee hyperextension, then he had a cut, it's not done by me, but then he had a cut of the knee extensors and he went to severe knee flexion again. This is not quite a nice game.
Rinald, can I ask a corollary to that comment of yours on gait lab? So if you don't have a gait lab luxury, how do you then decide?
Then I decide by my tests with clinical. I do actually the same tests, but I have an objective and a subjective assessment. The subjective assessment is patient and mine. And the objective data is coming from the gait lab. I do the same thing. I do use my conservative tools. I do use botulinum toxin. But if I have objective data, it actually helps me to strengthen my decision. But if I do not have a gait lab, I still do these tests.
Yeah, so
yeah.
You still do it because
I only explained about the gait lab because that actually, you see, gait lab is always producing more than just giving information on an individual patient. It tells you more things. Like that's what we learned, that we should actually consider other reasons and causes for equinus deformities.
Thanks for that clarification. Yeah.
Sorry. Should I take the question from the audience?
Yeah, please, Swapnil.
Yes. So the next question coming in is, do you ever tend to undercorrect the equinus deformity when the child is slightly younger, so that even in case you don't stretch out the ankle and cause a calcaneus deformity? Do you ever do a surgical undercorrection of equinus?
I do not quite understand the word undercorrection. So I do have different aims in the degrees of dorsiflexion. Yes, I go for a dorsiflexion of 20 degrees in a hemiplegic patient, but I only go to 0 or better -5 degrees in a diplegic patient and in a tetraplegic patient as well. So if they are bilaterally involved, I never go or try to avoid any dorsiflexion because they really have a tendency to go to crouch.
Just Swapnil, can I add on to this? The problem we face is like when the patient is under anesthesia. Yeah. During surgery, we feel that we have achieved whatever is the aim is. But as soon as patient comes out of the anesthesia or as soon as they start walking, we see more of equinus than what was there at the time of surgery. So how do you avoid that problem?
This is a difficulty because you see, the problem is that I inform the patient that gait is not a purely mechanical thing. And if the problem is that what you are actually talking about is a very difficult issue, because this is why did the patient produce the equinus? If the cause of equinus is feeling insecure, the feeling of the anxiety of falling, which is very important in these patients, if this is the cause, then they actually overactivate their triceps muscles again, and they produce more equinus. But the solution cannot be that I make the equinus so weak that he can't or she can't do that anymore and ends up in crouch. So this is very difficult, and that cannot be solved, in my opinion, unless you find a way that the patient feels more secure on his legs, safer in his positions. And that's when orthotics come in, even after surgery, or where the multi-levels come in. If I do knee extension and foot corrections at the same time, I have a better outcome, even in respect of this problem of additional plantar flexion, because the patient feels more at ease when he's upright. And I only, in the last few days, looked at my patients after multi-level surgeries, considering the reduction of orthotics. And most of them actually have only plantar supports or nothing anymore. That is because they actually feel more stable. And I looked at spasticity as well, and they have much less spasticity. The Ashworth scale is down. And I didn't touch anything else. So I didn't do anything to the motor control or to spasticity. And that means, yes, if I put the patient in a position where he can feel safer, spasticity comes down, plantar flexors are less, but you cannot guarantee. And I think that is something that you need to inform the patient beforehand. This is also a problem of cognitive functions. If the patient is able to learn that he is stable in his new situation, that's fine. If he is unable, he will have problems as well, and it will occur. I know that this is not orthopedics anymore, but it is essential that we realize that we cannot correct with our mechanical access patient deformities which are produced by other causes. And that's especially the case in cerebral palsy. But we need to understand why. We should not just say it's brain damage and I can't do anything. We should work that up and understand why the patient is in this difficulty. And I think if I can explain that to patients, then they are clearer, even for their not expected postoperative results.
Can I ask 2 quick questions? Reynold, the duration of physiotherapy, how long a parent should be counseled is the minimum? Because I see them going for days and days together, for hours and hours doing therapy. Just the minimum, so that the quality of life of the parent and the child is not affected. The same thing for the minimum duration of orthosis that you recommend.
Okay. Orthosis is easy. I leave them in orthosis until they have recovered their muscle strength. That's it. Then I reduce the orthosis. Physiotherapy, that would be another webinar, because I think that physiotherapy has very different aspects. One aspect is stretching. I don't consider stretching a really efficient thing that physiotherapists do. Unless you did an intermuscular lengthening, then it is required. But still, stretching orthotics are then better and more efficient than physiotherapy. Physiotherapy does muscle workout, so they work on muscle strength. That is something that should be done, yes, but the patient needs to do it himself. The physiotherapy can only motivate the patient to do so. And if the patient is not cooperative, or if he is not cognitively able to follow the instructions, that will not be helpful. And the next thing is we should consider what I initially said, motor development and learning. So we actually should introduce other activities than walking. We should not concentrate on walking. We should have activities like climbing, like jumping. I always tell them hip hop would be a good idea because that is fast, that is highly demanding for body control, and there's a lot of motion. Of course, most of them can't do it, but to a certain degree they can. And I think this is what is far more important. We should enlarge the spectrum of activities to improve our gait pattern and to improve our motor control. And that is something which is not yet included into physiotherapy. And that's a problem, because that is something which is the main purpose of our rehabilitation. That's where I see the main focus. I discussed this with neurologists in Germany and in other countries, in Italy and with us, and they actually agreed. It is the complex thing of motor control that we should work on, and not on a simple thing like gait.
Yes, it's okay.
So
yes.
I cannot define how long should you take physiotherapy, because it depends what the physiotherapist does. If he does stretching, he can stop immediately. If he does muscle workout, yes, okay, then it's fine until the patient recovered strength. If he works on motor control, there's another, it's another goal, and the goals take different time distances.
Right.
Yes, Vakil, please.
Yes. So the next question is, what is your philosophy about the pathology of varus and valgus feet? And what is your preferred method of surgery for a severe planovalgus foot?
Okay. As I said, I tried to explain it in my talk. My main philosophy is that the plantar valgus foot is a deformity which occurs because the patient is toe walking, circumducts, loads the toes before the heel touches the ground, and the foot still moves medially. So for this reason, actually, there's always a push on the foot into valgus abduction deformity with every step. And that's why most of these patients, especially diplegics or bilaterally affected patients, produce this valgus deformity. There are patients, but it's much less the case in walkers where there's hyperactivity of the lateral muscles. But as I said, yes, in GMFCS 4s and 5s, but much less in the GMFCS 1s and 2s. For the varus deformity, this is muscle pull. So my philosophy is I splint patients who are toe walking to avoid the deformity. And I try to, because always there is a midfoot instability in these midfoot break patients or valgus abduction foot patients. My main surgery is a calcaneocuboidal lengthening fusion. That works well in most of these patients. Sometimes combined, sometimes not, with a subtalar fusion. Whereas in the more active part, deformity like the cavovarus deformity, I actually tend more to do a tibialis anterior split. Not a tibialis posterior split, but only a tibialis anterior split transfer. And if there's a bony deformity, then I do a respective bony correction. But I think the cavovarus foot is more a function problem due to muscle problems, and their muscle surgery is well indicated, whereas the plantar valgus foot deformity is more a load problem, and for that reason needs another treatment.
I think there is one more question, but you may have partially answered it. So this is, what is your experience with the use of inhibition casting, if you use it, for a correctable spastic equinus deformity? So,
as I said, casting works, but it works only for a short time. So I've never had a patient who did not have a recurrence after casting. And for that reason, I think this is not quite a solution, because with a cast, the patient has less information considering the sensory input. He has less activity. He's losing certain habits that he has for walking, habits that he should actually have done every day to maintain his walking ability, so that there are drawbacks of casts. And the profit of casts in my hands is not big enough. I think in this case, it's easier because you anyway, talk about 6 weeks of casting, and you do that repetitively. And it is easier in this case is to do surgery first and do 6 weeks of cast, but no repetitive casts.
So those are the questions coming in from our viewers. We are done with those questions.
Yeah, so now let's go for the case discussion. Yeah, so this is a case of Dr. Gopakumar. I am trying to run from here, considering that my net connection is good. So let's see how it goes. So this is about a gay girl who is 13 years. She's at GMFCS level 3. There is a history of hamstring surgery in the past. At present, she does not use any orthosis. This is her video.
Shall I comment?
Yeah, please.
Okay, what you see is that she's actually keeping the foot in a more or less plantigrade position in the lateral view. So there's no severe equinus, and she actually is toe loading. And when you walk her when you see her from the front, when she's walking, you actually see the external rotation occurring under load. So she is exactly the patient where the load of the foot of a foot which is loaded by the toes first is producing the deformity. And then, of course, this foot gets very short because the midfoot break, which she has, makes the plantar flexor knee extension couple very inefficient, and she has long knee extensors, and that together produces her gait pattern. So she's not capable to extend the knee. She's unstable on the foot. If she's unstable on the foot and the knee, then she actually has no stability to forward the swing leg as she should. She touches prematurely before the leg really is prepared. She needs to catch up actually because she's falling, and she does so and overloads the foot again on the other side. The same situation occurs on the other side, and that's how this gait deformity develops.
Okay,
and
so
I'm
this
not
is
sure whether it would be my question, how much did she profit from hamstring lengthening? I do hamstring lengthenings in these cases if they are doing only transfer function or walking on a deambulator, but I try to avoid it in patients who walk independently because of the control on the pelvis.
No, the patient was operated for the hamstring surgery somewhere else, and now the patient is with Dr. Gopakumar.
But I just wonder what changed after the hamstring surgery. Is the knee more extended?
Yes, Dr. Gopakumar, can you tell, was there any improvement with hamstring surgery?
She's 13 now. This hamstring surgery was done at the age of 4.
Okay.
And she was given a brace and she discontinued that.
Okay, so that's okay. But now I think it's not the hamstrings which is causing the problem. It's the midfoot break. So the foot problem is an important thing. You see, she's out of plane. She has a midfoot break. She's loading with the toes. She has a knee problem because the knee is not extended. And I don't know, I would correct if she has a fixed knee deformity, you should correct the knee. If she has long knee extensors, you should correct the knee extensor strength. And at the same time, you should go to the foot and correct the unstable foot. I'm not sure whether she has really short triceps muscles.
Okay, so let's let me give you more information. Probably this information may be useful to you. Yeah. So on clinical examination of the feet are passively correctable.
Yeah.
Okay, on dorsiflexion, if we examine the dorsiflexion without correction, we can achieve 10 degrees of dorsiflexion. However, as soon as we correct the foot, we cannot achieve beyond 10 degrees of plantar flexion.
So we have actually 20 degrees of dorsiflexion which occur without any control of the patient.
Yeah.
Because this movement in the foot cannot be controlled by any muscle that we have. And for that reason, this is actually something which can only be overcome by even more plantar flexor activity. So even the more she pushes, the more this foot goes into deformity. And for that reason, she has these 10 degrees of plantar flexion deformity because it's not very much. So I would actually consider some kind of a mild intramuscular lengthening together with the foot correction, but not more. Not a heel cord lengthening. Okay, but I think 10 degrees is just the limit where you can ask yourself, yes, should you or should you not lengthen this? She seems to be pretty well considering her cognitive functions just from the impression. And for that reason, I would actually try to correct the foot a little bit more than just leaving it in plantar flex deformity. But I first would do the bony correction, see how much of plantar flexion is then remaining, and then I would do it if there is still a plantar flexion deformity. Because sometimes when you correct the foot, you do not get the full correction. And she may actually end up with 5 degrees or 0 degrees of dorsiflexion, or 5 degrees plantar flexion or 0. And in this case, I would leave her alone.
So which type of surgery you will consider for the foot?
In this case,
yes,
I would consider, depends on the supination deformity. If she has a supple foot, I would do a calcaneocuboidal lengthening fusion to provide stability to the midfoot joint. And if she has a rigid supination deformity, which is major, then I would do a complete Chopin fusion. That means talonavicular and calcaneocuboidal. And if it's a mild supination deformity, you actually can take a wedge out of the cuneiform bone and correct it that way. It's the same, actually.
Okay, and would the knee deformity make any difference in decision making as far as the foot is concerned? Like if I give you the more information about the knee.
I would correct the knee. Yes, okay. So there is a knee deformity. There is a fixed flexion deformity, which is important, which will cause a recurrence of your foot deformity. Less if you have a fusion, but still it is there. And the patient will still walk with a flexed knee. So there is no major gain if you only did the foot. And for that reason, I think there is no question. I would do the knee surgery as well.
Okay. Now some practical questions.
Yeah.
Like if we require to do both the procedure for the knee as well as feet, will you do everything, the 4 surgeries, both knees, both feet together, or you will stitch?
No, I would do it together. Because
all the 4?
All the 4. Because if you leave one side, during the recovery period, the other side needs to readapt at the deformity again. I have done that earlier on, and actually I have given up because I saw that my corrections deteriorated during the rehabilitation period because the other side was still in the deformity. And if you only do the feet, then you have the knee problem. If you only do the knee, then you have still the foot problem. So yes, if I really need to take these surgeries apart, I would probably start with the knee first and do the foot afterwards. And, because the foot can still be corrected by a kind of an orthosis, but the knee not. So the knee is something that you can only correct by surgery. And what I would do is I would correct the knee, and if I cannot do the foot at the same time, would splint the foot for a certain while. Maybe only giving a heel rise could be enough, and some kind of a plantar support which corrects this abduction deformity of the foot, and then do the foot in a second go.
Right. We should like to understand what are your views about tibial torsion? When do you consider tibial torsion? So first of all, how do you evaluate tibial torsion? And when do you decide that this tibial torsion needs correction or requires correction?
As I said, I thought about this tibial torsion because, as I showed, my patients always have the feet aligned in the direction of gait, and I hardly ever have abnormal tibial torsions. Whereas I've visited other colleagues, they actually splinted the feet in 90 degrees in abduction external rotation, and they had abnormal torsions. So I think it really depends whether it's there or not. What I do in my patients, if I'm not quite sure, I first do the foot, look at the alignment of the foot, and if there is a remaining problem considering tibial torsion, I would then add on a tibial torsion osteotomy. But I first do the foot, because you anyway need to have a stable liver arm. If you first do the tibial torsion and then did the foot, then you may actually have an overcorrection.
Reynold, what would you do for the flexion deformity in presence of a prone rectus positive and an extension lag of 20 degrees?
I would still shorten the knee extensors, but I would consider rectus release. I'm not sure whether rectus spasticity is really a problem, because yes, and we're still trying to publish this. It's very interesting. The rectus actually, not in all, but in some normal patients even, is active at the transition between pre-swing and initial swing. And it actually is active not only as a hip flexor, but also as a knee extensor. It gives a push of the leg to go to extension. It actually has part of the, is part of the muscles which accelerate the biarticular pendulum of the leg. If you take the rectus off, you have toe walking. This is interesting. If you weaken the rectus, the patient is not getting a heel-toe gait anymore. And if you overactivate the rectus, you have the typical military gait pattern of the parade. This.
So for the flexion, how are you correcting the flexion?
The flexion of the knee by an extension osteotomy.
Okay, I just want to clarify that.
Okay, a flexion shortening osteotomy. Always take out a wedge.
Will you correct the patella alta, which is present in this case?
Yes, that's the same thing like the shortening the extensor system. Yeah, shorten the knee extensors where the length is where it's overly long. It is usually the patellar ligament, and by shortening the extensors there, you actually pull the patella down. But in some patients, actually, you have a normally long patellar ligament, but a long rectus tendon. In these cases, you need to shorten the rectus tendon, the quadriceps tendon.
So
this is rare, but it happens.
Stiff knee problem post-operatively when you pull the patella down, because already the prone rectus test is positive here.
Yeah, but I still can get it down. And you only will have a stiff knee gait afterwards. That's the result.
Yeah.
Yeah, but it's still feasible that you pull the patella down. And if you have a stiff knee gait afterwards, you can still do the rectus release, because you have to take out the metal of the femoral extension osteotomy anyway. Yeah.
Okay, thank you very much, Reinald. Just now, I request our secretary Sandeep Patwardhan to say a few words about your lecture and as well as the summary of the session. Please.
Thank you, Dhiren bhai. Let me just first thank Reinald for the wonderful philosophy that he comes up with every time, and makes us realize that cerebral palsy is the problems are not only in the patient, they are in the eyes of the beholder. So it depends on who's examining him, what is his philosophy, how he understands the disease, and how best he can facilitate that child to harness his own adaptive mechanisms and help them so that he can walk a little better. So there are more than one ways to skin a cat, and Reinald has every lecture of his is an eye opener and makes you think and rethink and re-wonder about all the books that we have read, and question actually how the child adapts and behaves in CP so that we can apply some of the principles. I thank Matthew sir for his succinct summary at the end of Reinhardt's talk itself, Swapnil and Gopakumar for their questions, and I'm sure that all of us will be stimulated to learn more about CP and get more input from Reinhard in the future. So thank you very much. Good night and stay safe.
Thank you very much to you as well.
Bye-bye. Thank
And
you.
hope to see you personally soon. Bye-bye.
Yes,
Yeah, exactly.
I think all of us should spend some time with you in Basel to know more about your thought processes,
It's worth
because
it.
this cannot end otherwise.
Welcome.
Thank you, sir, for being live session,
Okay.
sir. Thank you, sir.
Good night.
Bye.
Yeah.
Bye-bye.